Hello, my name is Ekaterina Filatov, and I am one of the assistant researchers that worked on this project where we studied metabolic and inflammatory profiles of patients early into a diagnosis of enduring mental illness in northern British Columbia. People living with enduring mental illness, EMI, experience significant medical health disparities when compared to the general population, including higher rates of cardiovascular disease, diabetes, and bloodborne infections. The term EMI encompasses mental health diagnoses that have psychosis as a feature, such as schizophrenia, spectrum disorders, and bipolar disorders. The various comorbidities have underlying abnormalities such as increased central obesity, hypertension, impaired fasting glucose levels, and impaired plasma lipid levels. These comorbidities correspond to 15 to 20 years reduced life expectancy compared to individuals without enduring mental illness. Although these measures are monitored, pro-inflammatory cytokines are yet to be used as blood markers, even though there have been many lab-based studies demonstrating a causative association between low-grade inflammation, metabolic disease, and even mental illness. Clinical evidence showing associations will support mechanistic studies aimed at identifying common pathophysiological mechanisms. The aim of this study was to characterize cardiometabolic profiles and circulating inflammatory markers from clinic-referred participants within 6 months of first-break psychosis and diagnosis of enduring mental illness compared to age and gender-matched controls from the same community. This was a cohort study where we collaborated with early psychosis intervention program and researchers in Northern Health. Clinicians would refer EMI patients that met the inclusion criteria. We conducted interviews with our participants, collecting information about their physical condition, mental health, physical measures, and accompanied our participants to blood draw appointments so that the various listed biochemical measures could be assessed, and we performed sandwich ELISAs specifically for interleukin-6 and tumor necrosis factor alpha. We communicated these measures to the participants' GPs and clinicians. The analyses we performed on the collected data included t-tests and categorical tests for the means and tallies of various measures between EMI participants and the controls. To test associations, we performed Pearson's correlations. Now, just a quick look at the demographics of our participants. We show in Table 1 that our EMI participants and controls were age and gender matched and had no differences between exercise frequency and alcohol consumption. However, there are significant differences between groups for ethnicity, smoking, and marijuana use. Also, I'd like to highlight that the level of education differs significantly between control and EMI participants because control participants were recruited from post-secondary institutions. Now, moving forward to our results. Table 2 is based around metabolic syndrome, which is defined as a cluster of conditions that can lead to cardiovascular disease, diabetes, dyslipidemia, and other health problems. These conditions are included in the table. When comparing the number of individuals that meet each criteria, there are no significant differences between controls and EMI participants. But when looking at the amount of individuals that meet 0, 1, 2, or 3 and more criteria, we see that there is significant differences between controls and EMI participants meeting no cut points for metabolic syndrome. Our next main point examines the underlying abnormalities of diabetes, dyslipidemia, and obesity. In Figure 1, we selected measures that are related to metabolic syndrome, as well as BMI, as it is a common measure used for assessing metabolic health. Waist circumference is significantly higher in individuals of EMI, but we also see trends of increased BMI, triglycerides, plasma insulin, indices of insulin resistance, and beta cell function. However, some of these measures are not shown in Figure 1. In Figure 2, we show 4 different blood markers of inflammation: interleukin-6, tumor necrosis factor alpha, C-reactive protein, and white blood cells. Between our EMI participants and controls, EMI participants had significantly higher circulating tumor necrosis factor and white blood cells. Now in Table 3, we present correlations between the 4 different markers of inflammation that we assessed in Figure 2 against waist circumference, fasting blood glucose, insulin, triglycerides, and HDL cholesterol. As EMI participants showed trends of having greater absolute values for each variable, we can see that this led to there being some associations. Specifically, in EMI participants, we see C-reactive protein being positively correlated with waist circumference and also fasting blood insulin. Interleukin-6 was positively correlated with waist circumference and also triglycerides. Additionally, white blood cells were positively correlated with fasting blood glucose. Interestingly, though, there was a negative correlation with tumor necrosis factor alpha and fasting blood glucose. Now, to recap the study, we see that less EMI participants were meeting no criteria of metabolic syndrome compared to control participants. From measures of anthropometric data, cardiometabolic health, and inflammation, we see trends and significant comparisons highlighting that EMI participants who are rather young individuals are starting to show emerging signs of various comorbidities, with Table 3 showing significant associations between inflammatory markers and cardiometabolic markers. We add to the research supporting that inflammatory markers might be a useful criteria to add to the definition of metabolic syndrome and perhaps in monitoring health of EMI patients. Our team would like to thank the EPI teams for all their support and expertise and the participants who graciously gave their time to be a part of this study. And thank you for visiting our poster.